So today we're taking a look at what was a likely meniscal injury. I say likely because, as you will see, the person in this case study never had it confirmed that that's what it was. And we'll address why that is here in a moment. But let's continue on. Let's dive right into it. So you have the knee. And the knee has a lot of ligaments. It has some tendons. For those of you who don't know, ligaments are bone to bone. Tendons are muscles to bone. You also got the patella, the femur, the tibia, and the fibula, which you can all see here. You also have the meniscus, or the menisci, which are not present here, which is the point. So the menisci are what sit on top of the tibia. They're soft tissue that help keep the joint in congruity. And they can be torn and they can be injured just like any other tendon. You usually see meniscus injury with like lateral collateral or medial collateral ligaments, which are like if you're a football player and you see someone take a really bad tackle from the side and their knee moves in a nasty way that it shouldn't sideways, that's when you're thinking collateral ligament injury and meniscus injury. But they can also happen through repetitive motion, specifically rotation through the knee, twisting through the knee, because the knee's not meant to twist that much. But anyway, the takeaway here at this slide is you have an x-ray, and you're probably noticing something, which is the x-ray doesn't show a whole lot of soft tissue. Yes, there is, by soft tissue I mean tendons, ligaments, and muscle. Yes, there is some currently present. You can see a little bit of it, this ghostly after image, if you will, in there, but not nearly as much as in this image. So this is an MRI, and as you can see, there is a lot more detail. You can see a lot more soft tissue. You can see tendons. You can see ligaments. You can see muscle. This is much better at helping you see the soft tissue injury that could be there. You know, you might be asking yourself, x-rays, why? Why do we do them? Well, they're cheaper, and they're very good at spotting fractured bones, which is your chief concern in emergent medicine. These are much more expensive. In the area where I am at, a MRI can go between $1,000 and $1,200, and you have to be still a lot longer. You have to lay, obviously, in the giant cylinder while this really loud machine spins around you, and some people are claustrophobic and they can't handle it, and etc., etc. Long story short, X-ray, cheaper, immediately rules out fractured bones, which is one of your chief worries. MRI is really good at looking at soft tissue. So you can see here that if there was an injury to the meniscus or a ligament or a muscle, you would probably pick it up, especially if you're trained to read it. Now, the person in our case study never got an MRI, and the MRI would be your gold standard to know if they had a meniscal tear. That or like a joint arthroscopy where they go in and they actually look. But he did not, so we don't know for sure that he had one. So let's get into his story here in the next slide. So here we have Jay, the postman. He is 26 years old. He works in the postal industry, and he routinely lifts packages in excess of 35 pounds. What I mean by that is this guy's out here lifting 50, 60, 75-pound boxes every day for 6 hours a day. He's lifting a lot of weight. He's in very good shape. He always has been. Since he was at 18, he has been working out religiously. But here, for his mechanism of injury, MOI, we can see that it happened while he was lifting and twisting through his knee with a particularly heavy box. And then he felt a pop in the knee. So not good. The next day, his quads, knee, and calf swelled up significantly, and he was unable to flex his knee. Bad. His pain was a 7 out of 10 when twisting through the knee or when bending the knee, flexing it. Otherwise, it's swollen and tender to touch around the knee, but not significantly. He said it was tender, like he could feel it, but it wasn't quite painful. And the 7 out of 10, it took a lot. He'd have to crank on it pretty hard to get that in there, to get that pain to level up there. His chief concern, though, and this is where you might be thinking, hey, this doesn't actually happen. They just did this in the curriculum at school, but it does. Jay doesn't want to miss work. He wants to work through the pain because he doesn't want his boss thinking that he isn't able to do the job. So these patients do exist, and I guarantee you're friends with some of them. So after talking to him, he called me, said, here's what happened. But I said, well, you should probably go and see a doctor, which is really good advice if you can afford it. So he went to the urgent care, got an x-ray done. X-ray came back negative, which he told me, he said he was fine. I said, no, wait a minute. X-rays are really good at picking up bone, not meniscus, not ligaments, not tendons, not the things that I'm thinking would be injured with a rotational injury to the knee. Like, it'd be one thing if the 75-pound box fell 8 feet and dropped on your knee. Then I'd be like, oh, okay, this could be, fracture. But with rotation through the knee, I'm thinking ligamentous. So I tell him this, and he says, well, how long does it take for a meniscal injury to heal? I was like, well, it depends on the severity, but a minor one, maybe between 4 to 8 weeks. And he says, and you can look that up on, I think it was WebMD or Healthline or one of those big sites. They say between 4 to 8 weeks. And he said, well, I'll just wait 8 weeks, and if it still hurts, I'm going to go get an MRI, I guess. And I said, that sounds like a terrible plan. You should go get one now. But you have to work with the people as much as they'll let you. So let's get into the tests that I thought about and the ones that I had him do to rule out or rule in ligamentous or tendinous injuries. So let's remember the MOI. The MOI is making me think ligaments. So I got all of them listed here. I got my ACL, my PCL, my LCL, my MCL, and I got meniscus. So Lockman's test, which we're looking at that ACL, negative, nothing. And keep in mind though, we do have to consider that it is significantly swollen, and a lot of times when you're doing a Lockman's test, at least according to what the books say, and the tissue is significantly swollen, you can get a false negative because the tissues are constricting and holding that knee in place. So then we do the valgus, and we do the varus. We take the knee side to side, put pressure through. Both of those negative, no pain. No tenderness either when I palpated those areas, specifically over the where those ligaments would be, which would be medial and lateral. And then finally we do the modified McMurray's, and we have a positive, which again just makes me think it's meniscus. Again, he says, when does this heal? How long does it take to heal? What can I expect? And luckily for him, he was already doing rice. He was already resting it as much as he could, icing it, compressing it, and elevating it because his wife was all over him, making sure that he did that. So the swelling went down actually pretty quick. Took it, I think it was within like 72 to 96 hours. It was done. It was down significantly. But I told him again, 4 to 8 weeks, a month to 2 months is what's normal for a minor meniscal injury. Major ones require surgery. He's like, oh, I don't like the sound of that. I was like, nobody likes the sound of that. But why wouldn't we just go and get the MRI done to see if that's what we're dealing with? Which again, ultimately said, no, I'm going to wait the 8 weeks before I go and do that. So then the question is, what do we do? And the answer to that is, I tried to modify his exercises so that way they would be more like interventions instead of stressing the tissue. Because the last thing that I want to see happen to him is he's doing this acute on chronic injury where he has a chronic underlying issue. He's just acutely going back and re-inflaming it or re-aggravating it, re-harming the tissue 3, 4, 5, 6 or 7 times a week. So I said, hey man, we need to lower the intensity of your exercises. If you're doing any exercises, which it turns out he was doing a 3-day workout split on top of all of the lifting that he was doing at work. I said, you gotta tone that stuff down. So he was doing squats, lunges, calf raises, sprints, single leg deadlifts, push-ups, bicep curls, pull-ups, all that good stuff. I said, hey, Jay, you need to stay focused on stretching and pain-free exercises. Specifically, we want to do pain-free exercises in squats, lunges, calf raises, hamstring curls, which are all things that involve the knee moving. Less so calf raises, but again, you deal with some muscles that cross the knee, like the gastrocs, right? They cross the knee. So I'm just thinking I want to really cover all my bases and make sure that we're not going to go in there and re-aggravate that tissue. So we really need to talk about calf raises and stuff too. The stretching, though, is interesting. So I'm always interested in preserving range of motion, right? In school, they ingrain in us range of motion first, strength later. It does no good to be strong across a tiny range of motion when you could or should have full range of motion. The problem is you're dealing with aggravated tissue, and it's swollen tissue, and it's not happy tissue. So it's not going to want to give you the range of motion because it's all inflamed. So that's important to remember. So sometimes you have to wait. Well, not sometimes. You almost always have to wait for the acuity of the injury to go down, for the inflammation to go down, the swelling to go down, to go in and start doing range of motion. Even then, you have to do pain-free range of motion, working back into full range of motion as the tissue allows. But the best interventions, at least according to what I've read, are gentle, pain-free mini squats and half squats. Not going to full depth because that puts the ligaments, the meniscus, under significant strain, and you don't want to do that early on. The other one is you want to do straight leg raise. That's where you're laying on your back, activating the quads, bringing the toes back towards you and doing a nice raise. Hamstring curls, which is where you're laying on your stomach and you're bringing you're bending your knee, bringing your heel up to 90 degrees and controlling it on the way back down. Heel slides, which is when you're laying on your back and you're dragging your heel across the floor, kind of trying to push in there as much as your hamstrings can without pain. And then leg extensions, which is you sitting at the edge of a chair and just kicking your leg out straight in front of you. So this should honestly say Jay 1.5 months later, because now we've already crossed the 2-month threshold as of the recording of this video. Also, Jay is not his real name in case any of you are concerned. So, not out here releasing anybody's information. His leg is no longer swollen. The pain has significantly decreased, and it only manifests, it's only reproducible when he's twisting through the knee. When he flexes the knee, it's fine. When he extends the knee, it's fine. But when he twists through it, it gets a little twinge. Also, what he said, which was really interesting, was it's the weirdest sensation and the weirdest feeling. It just feels like instability in my knee, which, is not good. We don't want that. So now what I'm thinking for his interventions is a little bit more strength, because we want him to start stabilizing the knee joint, because he starts to say things like, I don't trust my knee now, and that's not what you want to hear. So doing focused interventions on strengthening the knee, so that way it's more stable. That way the patient, or in this case your friend, trusts the knee. So plus we've passed now the 8-week threshold. His irritability is low. It's probably time to start doing some strengthening. But yeah, this was the case study of one of my friends who had this mechanism of injury. It very likely was meniscus. He still won't go and get an MRI, so we don't know for sure. But we can see how him sticking to this modified intervention program and doing the exercises that we've listed, at least for him, worked. And this is a really good case study for how you can deal with people who don't want to follow the textbook. They don't want to go and get the MRI to get the diagnosis, to know for sure the condition they have, and you're still able to help them at least a little bit. So thank you guys for watching. I hope you found this informational. Please remember, this is educational. I am still a student in school. This is meant to be informative and to help you better understand at least some of the reasoning behind physical therapy and how we walk through our clinical reasoning to arrive to the conclusions that we do, at least how they're training me to do. And if you see this happen in your friends, family, or to yourself, you know now, if you get an x-ray and they say, yeah, you're all good, you can be like, yeah, but what about my ligaments? What about my tendons? That's what I'm concerned about. This was a rotational injury. You can advocate for yourself and say, I really think I need an MRI. And again, not medical advice. You should always talk to your doctor, but now you can see some of the reasoning behind probably what's going on in the general scheme of things. If they say, well, we're going to do an x-ray and then an MRI, they're trying to actually help you, probably trying to help you save a little bit of money, because if the x-ray comes back with a shattered femur, you can be like, yeah, we probably don't need to do that MRI, buddy. We need to get you healing that femur. So, again, thank you for watching. Really appreciate it. Please don't forget to like and subscribe. It really helps the channel. Leave a comment on what you want me to do a case study on next. You guys are awesome.